implement in the healthcare system in order to avoid the occurrence of such hearing loss. WHO has recently stated in 2021 that over 5% of the world's population, that is 430 million people, require rehabilitation to address their disabling hearing loss. It is in fact estimated by 2050 that over 700 million people, that is 1 in every 10 people, will have a disabling hearing loss. Therefore, it is of paramount importance for us ENT specialists to pick up hearing loss early. Starting with my case presentation, a 12-year-old female presents to ENT OPD with chief complaints of decreased hearing in the left ear for the past few months. Her mother reports that her child is not doing well at school. There is a 7-day history of left otorrhea and left otalgia, but that's self-resolved. There is no history of dizziness, tinnitus, headache, vertigo, nausea, and vomiting. The child is known with a right single-sided deafness since the age of 8, but was unfortunately not worked up. There are no previous bloods, CT scan, or MRI scan present. Fortunately, there is no delay in developmental milestones. She had a BAHA inserted in her right ear in 2019. Her perinatal history was uneventful, her immunization is up to date, and there are no positive family history of deafness in the family, and no TB contacts, and she is already unexposed. Her past audiological history is as follows. In 2018, when she was first diagnosed with a right profound sensorineural hearing loss. Her left ear was, however, normal. She had type A timbs bilaterally, indicating a normal, healthy middle ear function. Her ABR on the right showed prolonged fifth wave, and on the left, it showed normal waveforms. She was subsequently given a soft band BAHA in 2018, followed after a year by a right bone-anchored hearing aid. Unfortunately, thereafter, she was lost to follow-up due to COVID. The last audiogram available is from 2020, which showed a normal left hearing and a right single-sided sensorineural hearing loss. Now, in 2022, she presents with an audiogram, as we can see here. The left ear now shows a mild to severe mixed hearing loss and a reverse sloping type of pattern. This was done after the speech therapist and the class teacher requested the audiologist at school to test her, as they noticed that she was struggling to express herself clearly. A repeat audiogram was done to confirm findings, and indeed it showed a moderate to mild sensorineural hearing loss on the left side. On examination, her right ear was normal in terms of normal pinna, ear canal, intact tympanic membrane. She had a right preauricular sinus. Her left ear, her nose, oral cavity, and neck were normal. At this point, we made a diagnosis of progressive sensorineural hearing loss in the left ear in a background of a right profound sensorineural hearing loss. The investigation we took up for this child was a CMV PCR, syphilis, and HIV, which turned out all 3 negative, urine dipstick, and ECG, which was done at OPD, which was normal, and ophthalmology referral was done in order to rule out any retinitis pigmentosa in the view of Usher's syndrome. This came back negative. A CT temporal bone was booked, which came out normal, excluding any inner ear abnormalities. and a genetic referral was done and was still waiting for the genetics consultation. So let us have a look at what is profound sensorineural hearing loss. Sensorineural hearing loss as such refers to hearing loss due to defect in the sensory apparatus, the cochlea, which refers to the sensory component, or the neural component being the pathways of conduction of nerve impulses to the brain. The neural causes can further be divided as peripheral, involving the eighth nerve, and central, involving the auditory pathway or the cortex. Progressive sensorineural hearing loss accounts for 4 to 30% of hearing loss with an age range ranging from 14 months to 11 years. This wide range of percentage could be probably due to the different definitions available to define progressive hearing loss. In this paper in January 2022, there are different definitions for progressive hearing loss, but the two most common ones are the ones from Fitzpatrick and al. and Dahl and al., namely a decrease in hearing level of more than 20 decibels in 3 frequencies of pure tone average, 0.5, 1, and 2 kilohertz, or a decrease in hearing level of more than 10 decibels at 2 or more adjacent frequencies between 0.5 and 4 kilohertz. It's important for us to define the degree of hearing loss: mild, moderate, severe, and profound. But it's also very important for us not to ignore a mild hearing loss, as a mild hearing loss can eventually lead to negative developmental consequences and more often have a tendency to fall between the cracks. So how to screen neonates? We have the 136 guideline, which is that all infants should be screened by no later than 1 month of age. If they have not passed that screening, they should have a comprehensive audiological evaluation by 3 months of age, and by 6 months, appropriate intervention should be implemented. Now, there is the universal neonatal screening program that is very well implemented in high-income countries. Unfortunately, low and middle-income countries are unable to be able to do the universal neonatal screening because of financial resources, lack of ENT and audiology and speech therapists with respect to the population. And but as far as clinicians, we must be aware of how to screen individuals when they present to us for a medical consultation. The most common modes of assessment include evoked auditory otoacoustic emissions and an ABR. The ABR acts both as a screening tool and as a diagnostic tool. As a diagnostic tool, especially when we are suspecting an auditory neuropathy. In auditory neuropathy, one will encounter a normal otoacoustic emission, but an abnormal ABR. There is a wide array of audiometrical tests that can be done. Tympanometry is often coupled with OAE and ABR. A speech test in resource-limited resources, one can do the whisper test and tuning fork test. But what's interesting is also the HEAR WHO app, which has been invented in order to help clinicians in resource settings where there is a lack of audiologists. There is an app that can be downloaded on the mobile, and by plugging in earphones to the child, one can test if they can hear properly. Now, let us see what is the workup that we otorhinolaryngologists must take up when we see a patient with progressive sensorineural hearing loss. This involves a teamwork with audiologists, pediatricians, psychologists to rule out any functional hearing loss, radiologists, ophthalmologists, and genetics. Our aim is basically to address 2 questions Is there genetic factor involved, and how can the hearing loss evolve? I found a very interesting guideline published in January 2018 by the British Association of Audiovestibular Physicians on how to investigate progressive permanent childhood hearing impairment. Amongst considerations, the most important ones include to be aware of and to exclude if there is a middle ear dysfunction in terms of glue ear or ossicular erosion. One must note that children with auditory neuropathy may have fluctuations in hearing. And it's important for us to know that objective hearing tests and behavioral hearing tests may have variations. Our aim in investigation is to give timely treatment to medical conditions, which could be CMV infections, such as torch infections, congenital cholesteatoma, or even medical conditions such as thyroid dysfunction in Pendred syndrome. We also want to counsel patients if there are genetic causes, to counsel the parents and to also give appropriate advice. For example, if there's an enlarged vestibular aqueduct, this child will be at risk of progressive sensorineural hearing loss with even a mild head injury. How to suspect a child is having a progressive hearing loss? This is greatly aided by the help of parents, teachers, and medical staff suspicion. In an inattentive child or a hyperactive child with non-development of speech and poor performance at school. Let us see how the causes can be broadly classified. Causes of progressive sensorineural hearing loss is broadly classified as congenital and acquired. The congenital causes can further be classified as environmental non-genetic causes, which includes infection, anatomical abnormalities, and ototoxic drugs, and genetic causes, which includes syndromic causes and non-syndromic causes. There are around 300 syndromes available present that are closely associated with progressive sensorineural hearing loss. But among these, what one must know is that autosomal recessive diseases account for a large proportion of non-syndromic hearing loss. And amongst this, we've got Usher's syndrome, which is a syndrome that affects both the inner ear and the retina, as well as the vestibular system. There are in fact 3 types of Usher's syndrome: Usher's 1, type 2, and type 3. Of note, type 2, the child will present with retinitis pigmentosa, tunneling vision that crops up in adolescent age. And in type 3, there is a close, it is characterized by vestibular abnormalities alongside with visual disturbances and inner ear sensorineural hearing loss. There's also the Jervell and Lange-Nielsen syndrome, which is characterized by prolonged QT interval on ECG and cardiac arrhythmias. This occurs due to mutation of the gene that encodes for potassium channels and therefore affecting the endolymph pathway in the stria vestibularis of the cochlea. Pendred syndrome. Patients with Pendred syndrome typically come in adolescent age, and sometimes it's only when we do a CT scan and we see an enlarged vestibular aqueduct, we then order for thyroid function tests and eventually diagnose the child with Pendred syndrome. Among autosomal dominant diseases, we've got Waardenburg syndrome, Stickler's syndrome, which is associated with ocular and skeletal abnormalities, and bronchio-otorenal syndrome. Coming to acquired causes of sensorineural hearing loss, this can broadly be classified as perinatal causes, hyperbilirubinemia, infection, trauma, tumor, such as acoustic neuroma, and even noise exposure. Now, coming back to the guidelines divide in levels of investigation as level 1 and level 2. Level 1 investigation includes clinical history. One must clearly find what's the onset, duration, and progression of hearing loss. How is the speech of the child? Is there any balanced tinnitus or dizziness in the child? Of course, this is very difficult in smaller kids. And how are the developmental milestones? In clinical history, one must investigate and see how the antenatal history was. That is, was the mom on any drugs? Was she alcoholic? How was the maternal health during pregnancy? One should ask about the birth history, that is the perinatal and postnatal history. One should investigate on the family history and, if possible, do a 3-generation family tree to check for deafness in first and second degree relatives. And one should see the past medical history. What's the immunization status? Was there a history of meningitis, head injury, and any ototoxic medications? Prenatal history includes infant factors that are anatomical factors, and there are big number of abnormalities, including Michael's aplasia, Mondini's dysplasia, which I'll be showing later in my slides, and maternal factors, which includes infection, drugs, and radiation. The perinatal history we should ask for if the child is premature, of low birth weight, if the child spent time in ICU, if there was neonatal meningitis, jaundice, sepsis. And in postnatal history, one must find out, is the child exposed to noise? Because it's been found that mothers who work in noisy surroundings with their child have a high risk of sensorineural hearing loss. But also find if they are on chemotherapy, radiotherapy, if they had a trauma to the head. Trauma to the head, in fact, can lead to perilimb fistula, or even if there is trauma in a patient with an enlarged vestibular aqueduct, this can lead to progressive sensorineural hearing loss. Meningitis, especially bacterial meningitis, needs attention, because in these cases, there can be ossification of the cochlea, and such child would greatly benefit from cochlear implant. On clinical examination, one must note the anthropometry, systemic examination with a general overview of skin, spine, hand, abdomen, in order to exclude any syndromes, a cardiological evaluation, an ECG, to detect if there's Joubert and Lange-Nielsen syndrome, and to test an assessment of development. One must also be cautious and must check the palates as well as the craniofacial region for any abnormalities. Ear examination is very important for us to view the tympanic membrane and exclude an OME or any cholesteatoma. And a clinical examination can be done by various vestibular testing. Blood tests are quite controversial. So one could go ahead and, so in our institution, we go ahead to test for CMV, HIV, syphilis, because these are treatable, they are treatable conditions. But the whole lot of blood tests remains at the discretion of the clinician. What's important is a urine examination, where one should check for hematuria and proteinuria. Port's disease is an X-linked, most commonly an X-linked disease, but can also be autosomal dominant and autosomal recessive. And it is characterized by any 3 of the following 4: a positive family history of hematuria, a renal biopsy characteristic of Port's, ophthalmic signs, which include anterior lenticonus and macular flecks, and sensorineural hearing loss. Congenital cytomegalovirus is 1 in 5 most common cause of progressive sensorineural hearing loss in children who do not have an identifiable cause. And what's of note in this is that 90% of children are asymptomatic at birth. And these children can sometimes present in early childhood with hearing loss, which can be most commonly unilateral and progressive. Therefore, timing of this condition is crucial within the first 4 weeks and is treatable by IV, 6 weeks IV ganciclovir or 6 months of oral ganciclovir. Studies have tried to see if there's any benefit of IV over orals, but it has been found that oral ganciclovir is equally effective. CMV can be tested by taking urine samples or saliva swabs if the child is less than 1 year of age. If the child is more than 1 year of age, one can test for urine CMV DNA PCR. And at any age, one can consider testing the mother's CMV IgG and IgM. An ophthalmology referral is very important, not only to record the visual acuity, but also to view the fundoscopy. And in fundoscopy, we want to check if there is any retinitis pigmentosa, especially if we are thinking of Usher's syndrome. There are also other syndromes that present with ophthalmological association. This includes congenital rubella syndrome, congenital toxoplasmosis syndrome, Waardenburg syndrome, Alport syndrome, and even Alström syndrome, which is a metabolic disorder where diabetes is associated with sensorineural hearing loss. Other level 1 testings include family audiograms, genetic testing, not only connexin 26, but also profound genetic testing, including Usher's, serological testing, and autoimmune testing. Level 2 investigations, according to the guidelines, level 2 investigations are then done if we are suspecting specific conditions. For example, hematology, we can do a peripheral smear if there is a family history of sickle cell anemia, because it's been found that sickle cell anemia can be associated with progressive hearing loss. Biochemistry, if one has detected on CT scan enlarged vestibular aqueduct, one should proceed to do a thyroid function test to rule out goiter and Pendred syndrome. But also Mondini's deformity of the cochlea is also associated with Pendred syndrome, and therefore one must test for the thyroid function test. Metabolic screening in terms of amino acids, phytic acids, and mucopolysaccharidosis has been found to be closely associated with progressive sensorineural hearing loss. And in the Northern Hemisphere, there is a note that Lyme's disease is also a cause of progressive sensorineural hearing loss. One must proceed to do renal ultrasound if one sees bilateral preauricular pits in order to rule brachioautorenal syndrome. If one finds Mondini's defect or enlarged vestibular aqueduct on imaging, a metabolic screen is done if we suspect mucopolysaccharidosis, for example, in Refsum's syndrome disease, which is a paroxysmal disorder, sensorineural hearing loss, alongside with mental retardation, hepatomegaly, and abnormal eye exam is suspicious. There are other level 2 testing noted in the guidelines, which includes genetic testing, vestibular investigations, referral to rheumatologists if one is suspecting autoimmune disease. But there's also the comparative genomic hybridization microarray test, which is done for children we are suspecting autistic spectrum disorders. Now, there is a paper which was published in 1999 showing the audiological aspects of progressive sensorineural hearing loss. And it was found that there was most commonly high frequency ball-shaped audiograms recorded. And there was a tendency for greater deterioration at frequencies initially least affected. But the manner of deterioration across the frequency range is not uniform. What helps us greatly in investigation for progressive sensorineural hearing loss is imaging, either in the form of CT scan or MRI. In the picture on the left, you can see there is a condition called Michael's aplasia, where there is no formation of the inner ear structures. The curved arrow here shows the abnormal path of the facial nerve. The open arrow here shows a narrow internal auditory canal. And the straight arrow here shows abnormal ossicles. One cannot see any inner ear anatomy, and that's termed as Michael's aplasia. We've got the common cavity inner ear abnormality. Picture A is a CT scan and picture B is an MRI. This is an anomaly where the cochlea and the vestibule form a common communicating cavity. And then there's a cochlear aplasia here, where the straight arrow here, you can see there's no cochlea. And with this open arrow, you can see a cystic vestibule. And this is Mondini's deformity, which is defined as cochlear hypoplasia. So usually the cochlea has 2.5 turns. Here it may have 1.5 turn. There's an enlarged vestibular aqueduct and a dilated vestibule. CT scan also helps us to define the facial nerve anatomy, to find the integrity of the ossicular chain, to measure the dimensions of the internal auditory canal. And what's important for us is to always check the vestibular aqueduct. As in these children, one must give counseling to the parents. These children should avoid sports, activity, or any other activity, as even mild trauma can lead to progressive sensorineural hearing loss. Of note, the definition for enlarged vestibular aqueduct, it is defined as a midpoint diameter of more than 1.5 millimeters, or by the Cincinnati criteria, a midpoint width of more than 1 millimeter, or an opercular width of more than 2 millimeters measured in the axial plane. Those CT scans are easier to be done. MRI scans requiring sedation and being more expensive is, however, useful for us when we want to detect abnormalities of the membranous labyrinth. And when we want to view the auditory pathways and the cortex, when we're suspecting any lesion in the cortex or auditory pathway. Now, when to do further imaging? Suppose a child already had a CT scan and now presents with progressive hearing loss. Do we further image them? So the guidelines say we can if there are new unexplained symptoms of concern. For example, headache, dizziness, imbalance. If there's been a change in type of hearing loss, for example, if it was purely sensorineural and now it's mixed. If the child has had bacterial meningitis, we want to see is there ossification and fibrosis of the cochlea, and especially if we want to plan a cochlear implant. If the earlier imaging had artifact, and if the sudden drop in hearing is triggered by head injury, where then we want to see the ossicular chain. Coming to treatment of progressive sensorineural hearing loss. There's no medical therapy reported in literature. However, there have been trials with corticosteroids, and if one suspected Meniere's disease, diuretics. But the real treatment is by amplification through hearing aids. This could be behind the ear hearing aid. It could be contralateral routing of signal cross, where a speaker is connected to the abnormal ear, and the signal is sent then to the better ear for auditory purposes, or it could be a bone-anchored hearing aid. Speech therapy is very important as we want to ensure communication of the child. This could be either oral or by sign or both. Timely school accommodations should be done. So if a child is in a mainstream school, one must send the child to a special school where then an FM system can be used. The FM system is basically a system where the teacher wears a microphone and that communicates to a speaker on the child's desk. And of course, as last resort, cochlear implants can be done, of course, if the child fits the criteria. This is a paper in 2001 where acute progressive hearing loss in hearing impaired children, a trial was done using plasma expanders, pentoxifylline, and prednisone, and they tried to see, does hearing improve with this medical therapy? And indeed, 6 out of 7 of these children who got this, this mixture of corticosteroids with plasma expander and pentoxifylline did improve and restore their hearing loss. But what was of note is that this was an acute onset hearing loss, similar to that of sudden sensorineural hearing loss within 72 hours. One can attempt this, but this will not work for chronic progressive hearing loss. Finally, what are our goals of oral rehabilitation? We want to ensure there's improved speech, child is able to communicate, there's proper development of language, they're able to manage their hearing aids, and there is training in auditory perception. This is a diagnostic flowchart I made from the paper of diagnosis and treatment of workup of childhood sensorineural hearing loss, where children with a new onset of diagnosis of sensorineural hearing loss, one should always test for CMV and workup using CT scans and MRI and referral to ophthalmology and eye for to rule out syndromes. Before ending, what are the strategies one can implement in our healthcare system? So other than, of course, ensuring immunization, and one must be aware that we must always act on a parental concern. If a parent says that the child is having a hearing loss, one should always screen the child and have an audiological assessment. It would be great if babies who have risk factors for hearing loss, they should be tracked and they should have yearly audiometric analysis. It's also important for us, in patients with genetic associations, to counsel parents if they plan to have other babies. And it's also important and good if each country can implement an ear and health care in the national health system in order to address and hearing loss in the population. Some future goals could be nanoparticle drug therapy, to send drugs directly to the cochlea and sort of improve blood flow. Gene therapy, if one can replace and repair the defective gene, and stem cell transplantation. With this, I come to the end of my presentation. Thank you for your kind attention.
Divya, thanks very much. It's a very interesting topic. I see Silva is also on the call, so I have a few questions in addition to comments. The one is, I thought that the genetic syndrome, so that Usher and Pendred were actually genetic non-syndromic mimickers. So when you look at these children, and when they're born, they look fine, because you can't pick up anything clinically that they're part of a syndrome. Then they have deafness, and when you actually put them through the battery of tests, the ultrasound, the thyroid ultrasound, renal ultrasound, and ophthalmology referral, then it becomes apparent that it is part of the syndrome. So I thought I may have it wrong because I'm not a peds doctor, but I thought those were genetic non-syndromic mimickers, and the reason it was important to pick them up was because they could be part of the syndrome, and if you don't do those tests, you would miss that. Yeah, and then, so it's just important to get that terminology correct. And then the important causes of genetic non-syndromic causes, I'm not sure, maybe Silva can let us know whether they routinely test for those. So that's like the otoferlin deficiency, the connexin 22 and 26 deficiency. As far as I remember, the last time I attended a meeting, most of those tests were only available in the States, but that may have changed. And so, if you're working in a very developed world where cochlear implants, for example, are widely available, and you pick these children up, they would routinely send them for those more complex genetic tests because they feel that it does affect the cost effectiveness in terms of a cochlear implant program as to whether you implant them or not. So if that genetic deficiency is at the level of the inner hair cell, they would do well. If it was at the level of between the junction between the striatum vascularis and the nerve, they would not do that well. So even though those genetic mutations are very rare, they felt it was still justified in terms of testing it, because if you looked at the cost of a cochlear implant, it cost a hell of a lot more money. But obviously in our setting, one has to think of other causes like the infections, as you so correctly mentioned. But maybe Silva can tell us what battery of tests they actually do. I don't think they do the very complex genetic testing for these kids. I think it's just the basic. I don't think they test for connexin 22 or 26 routinely, and those account for the majority of progressive hearing losses.
The test for connexin 22 only.
Okay.
She's replied, "Hi everyone, as far as I know, South Africa tests only for connexin 22.
And Silva, is that in the state or is that only in private? Do they do that at Red Cross, or is that only available for private patients?
Exactly correct about one of the arguments in the States, etc., epidermatologists, is they will test for connexin 26 because connexin 26 is not associated with any osseous abnormalities, so then it negates the need for subsequent imaging.
Yeah.
So. Any other comments?
Hi everyone. As far as I know, in South Africa, they can only test for connexin 26, but it's not done routinely. It's usually done for the kids who are being worked up for cochlear implantation.
You comments from Newcastle?
Yeah, so we do genetic tests, and I don't know exactly what the list of tests they do, but there is a big cochlear implantation center in James Cook in Hillsborough, so they have a whole workup.
Yeah. Okay. Thank you very much. It was a very comprehensive talk and well put together. Thank you very much.
Thank you, Prof.